Good morning. Nice to have you all here today. So I'm just around the corner in the lab from where you're all sitting, and I'm standing here with our tissue sample. First thing I would say is feeling a little like I have a black box here because as any physician would before seeing a patient performing a procedure, we would be looking at our imaging, right? We would be looking not only at x-rays, but looking and reviewing, assessing our own MRIs. Of course, in this situation, it's not a possibility, so we'll see what we get. We have our patient, our cadaver here, prone on the table, and we have a C-arm in place. We can move over to the station to start to look and optimize imaging. All right, so is my technologist here? I'm going to ask you to take a picture. Thank you, Victor. Okay, so Victor and I beforehand just made a few adjustments to the C-arm position. What you can see is that I have centered around, typically I'm entering into the epidural space, typically about T12L1 or L12, whichever has the larger, more crisp edges evident for the central canal entrance interlaminarly. Once I center on that position, then I'm going to be typically caudally tilting my C-arm so that I have squared the end plates and get a really nice, ideally I like to see the superior edge of the lamina at the level just beneath where I'm approaching. In this instance, several possibilities here are reasonable. I think what I'll do is plan to enter between the T12 and L1 interspace. So I'm just going to begin marking skin, planning my trajectory.
So,
picture, please.
So Jennifer, as you mark, so yeah. She's going to start, I'll narrate here a little bit with what you're doing. So typically you start, this is your interlaminar space right here. These are the lamina, the chevron that goes like this.
Picture.
And you will start 1.5 to 2 levels below, because you don't want to go to make an angle to go superior. You don't want to start going directly perpendicular. You not be able to make that turn. You want to make the highway as straight as possible. So you come up like this, and typically if your start point is going to be, if she's aiming here, the start will be right where she's pointing. So this is, to get your trajectory correct straight away is very important.
So what I've done here is marked my skin at this location. Picture, please. So what you can see is that this is the needle that I plan to enter from an oblique, lateral to medial, approaching and entering into the epidural space between T12 and L1. So as we all know, doing an interlaminar epidural steroid injection, we would be kind of gun barrel viewing this needle, but in this instance, I need to plan an approach that is oblique. So this is my needle entrance location, picture, okay? Even a little bit inferior to that would be fine. This particular tissue specimen is thin, so I don't think there's as much tissue to traverse. My impression is that this will be a good position. Do we have
She's starting one level below. So the needleology of this, what type of needle is she using to put the epidural lead in? Oh, no trick questions here. It's a
shot, please.
TUI needle, right?
This is a TUI needle.
Which direction does the aperture, the opening of the TUI needle face? Is it the same side as the notch, or is it opposite the notch? Same side as the notch.
Would you repeat your question?
Oh, I'm quizzing our guests. Oh. So it's the same side as the notch, and it looks like this. It's hooked. And this is designed to feed like the same direction. So the lead will feed the same direction as the proximal notch of your needle. That's how you know it's there. Exaggerated TUI needles, they're bent even more with the secondary curve. Do you know what these are called? There's different brands, of course. Most popular of this is called an RX2 Coude needle. And so this is, if you have an exaggerated steering capability, it's also very blunt. I have seen somebody plunge right into the spinal cord with an RX2 Coude needle, obviously not on purpose, with no injury. But you turn it around, then it becomes a weapon, right? It's very sharp the other way around. So just make sure and understand the anatomy of the needle.
So at this point, I have approached the interlaminar space. The tip of my needle is at the superior edge of the lamina of L1. And my practice is to look at a contralateral oblique position now in order to assess depth as I advance into the epidural space. So what I'm going to have you do is oblique toward me, please, Victor, by 35 degrees, perhaps more if we have good imaging. Yep.
So this is one of 3 techniques: contralateral oblique, direct lateral. The other one is by just
You won't get me.
depth, anatomic depth. You know, if your needle tip is overlying the lamina, you'll feel bone, you won't go into the canal. Then you can go above it and just progressively take your lead or loss of resistance syringe or contrast syringe, making sure to get into the epidural space that way.
Okay, that's what we have then, shot.
The lamina is shaped like this, right? Contralateral oblique, if she's going on this side,
Perfect.
the II will be looking here.
So the 2 advantages of this position, in my opinion, are that we have an assessment of depth. And then secondly, I can predict a little bit easier the angle of approach into the epidural space.
Using the loss of resistance technique now. So people will ask me, what technique do you use to get into the epidural space? The only thing I don't use is this, because it's an extra step. But everything else, as Dr. Phillips, who has the great misfortune of being my fellow this year, has already seen every single technique: contralateral oblique, direct lateral, ipsilateral oblique. So, and we use combination of loss of resistance typically, but with contrast, you can use it with air. You can use direct anatomic visualization, so you can actually see. You know where the epidural space is in the direct lateral, and you can put your lead in and slowly advance your needle until you get into the epidural space using direct viz, anatomic identification of landmarks. So recognized method.
So you observed me advancing slowly while I intentionally lowered the angle of my TUI needle. You can see that the bevel of my needle is cephalad, so that it's going to cup, and the lead will naturally go cephalad. And you can see that the tip of my needle is just ventral to the spinolaminar line. We're going to go back to AP, please, or with the oblique tilt we have, or the caudal tilt we have.
So the notch has to be facing up. That means the blunt part is facing forward. If you have the notch down and you're advancing the TUI needle, we can't be friends anymore. You have to do always with the notch up. That means the blunt end will be toward the dura.
Sure. Shot.
So it's good position. You're trying to tag the very center
Can you move the C-arm a little bit?
of this
Just this much.
epidural space, because in the center of the apex, it tends to hug midline. If you get to the right or to the left off midline, it will drift to one side or the other. You could drift all the way to the anterior epidural space and look like you're in the midline, and you are in the midline, but you're in the anterior portion of the midline where the nerves come out and the stimulation doesn't happen there. It happens in the dorsal columns, the back. Yeah, this is a good demonstration. Dr. Schonard is demonstrating this. This is always oblique like this. You never go midline because the supraspinous, the interspinous ligament is too hard. Don't go midline. Go oblique.
Stop. All right. So we can look at lateral now.
Thanks.
So as I was advancing my lead out of the epidural needle, I was paying close attention to whether it stayed really directly within that probably 2 centimeters of midline. Anything more lateral than that, and there's the propensity for it to follow around in the gutter or in the lateral recess and move ventrally. I didn't see any of those suggestions, but I'm going to check laterally before starting my second needle.
So that's about as good as you get right there. Direct AP, and the spinous processes are in midline, so you know this is a direct AP. The pedicles are in the superior half of the vertebral body. The end plates are sharp. This is a direct AP. It's about as good of a view as you have. You see the epidural space starts back here. This is the epidural space. It's right, and the interlaminar opening is between halfway up the pedicle all the way to the pars interarticularis. This right here is the way that you know that you're at the appropriate superior inferior dimension. Then if you're hitting bone, you know you're either too far medial and too far lateral, but it opens right there.
Short, please. Yeah, that's good.
Okay, so you can see that my lead is in the dorsal epidural space. The tip of that lead is just probably tilted toward the lateral recess, but this is certainly a dorsal epidural lead. So we're going to go back to AP and begin entry with the second needle.
So that's about as good as you get. So two options, one are to come the other side, or one is to go just very close and try to get the second lead in very close to the first initial lead.
I could show it, but I'll use the other.
Advantage is if you
Yes.
provide copious amounts of local anesthetic, you just put another needle right directly adjacent
Then
to
go
that
south.
and use the same pathway. The disadvantage is you're entering one half of the lamina, interlaminar space. You'll have less space to enter than if you go on the opposite side.
So I'll show you a little difference here.
Yep.
On the screen, this is a Coude needle. This is a bit different than the TUI needle. The difference here is that there is a more acute angle than the TUI needle has. The last about 4 or 5 millimeters here has a more acute angle, and that can be a preference that you may have, or there may be instances where that's an intentional selection.
So the RX2 Coude needle is more steerable, it's more blunt distally, and this is something that if you want directionality, this is the king of the needles.
Picture. Yeah.
So I'm going to begin again on the left side now.
So as she goes down, if you're wondering about local anesthesia, provide copious amounts of
Shot,
anesthesia.
please.
What happens if you're unable to do a sufficient amount of anesthesia and the patient is writhing? You're just going to have to give more sedation. What if you don't have sedation? And just put more anesthetic.
You
So
need something?
what we typically do, what's called a thoracolumbar interfacial plane block, multifidus, longissimus, iliocostalis. Between the multifidus and longissimus, there is a neurovascular bundle. If you hit that bundle, that's an interfacial plane block. If you hit that and you do it, you can do up to 10 cc's of a mixture of bupivacaine and lidocaine. If you do that to either side, you can, as Dr. Schonard knows, if you do an effective interfacial plane block like that, you can put
Contralateral
medical
oblique.
screws in somebody.
Towards you.
So that's a
35.
good tip if you're not having sufficient anesthesia. T-lip. Anything that we say, just reach out to us. We're good communicators. I have videos and things on how to do this, and we have lots of additional things we'll make available to you.
Perfect. Thank you very much, Victor. So I'm observing the depth of my needle here. Since I had the tip of my needle was just coming cephalad to the superior lamina. I didn't feel that it was deep enough to be entering the epidural space, but there's the potential for that because I no longer have the ventral obstruction of bone. So that's when I moved to a contralateral, or it may be your preference to turn to a true lateral position at this moment. I can see here that the angle of approach could be a little more shallow, which would make potentially it easier to drive my lead in the dorsal epidural space. So that's one correction I'm going to make now. Shot.
So tip will come superior.
Shot.
And she's going down on the contralateral oblique. Here's the depth right there. And switch to loss of resistance syringe with air in it. And just slowly go down. You have the option of doing this. You also have the option of using contrast. I would dissuade you from that unless it's absolutely necessary because contrast makes things sticky. Contrast is viscous and it's sticky, so it causes leads to stick. The only time I will use contrast is whenever we're really, really difficult to see cases. Cervical thoracic junction, when we're working off a contralateral oblique, and sometimes the ligament inflavum is very vestigial. You can't really use any type of technique except for direct vis, and you can't see things, so contrast helps out.
AP.
But use it only when you have to because it will make feeding the lead difficult. Anybody know what kind of a lead that is? Just in general, 16 contact points. That's why you see up high, you see so many electrodes. They come in 4 I've used them whenever they had
Shot.
single electrode, and then they come in 4, 8, and this is a 16 electrode.
Shot. Shot.
So epidural space is accessed. It's pointed directly to midline. This is a good midline view right here. And she's going to feed it up just right directly adjacent to this. Targets in general include if you have abdominal pain, T5 for things like pancreatic pain. Also for angina, although in the U.S. we don't do this hardly at all. It's a European thing mostly. T8, anywhere from halfway up T7 all the way down to halfway up T9, that's back. And from that level, from about inferior T9 to T11 is legs. So this is kind of general target areas. And we center at, so this is her area right here. So this is 12, 10, 9, 8 right there. And to be able to make sure you're at 8 and to gauge your height, your superior, inferior, extent of how far up you are, you'll need to sharpen the end plates. So this patient is lying prone, they have a kyphosis, the eye is like this. You'll need to get a cranial tilt or caudal view to make sure that you're at the right level.
Perfect. So you see 2 dorsal epidural leads. The position of these leads, you can go back to AP. The position of these leads is traversing from about the lower 1/3 of the T8 vertebral body down and covering to the T10 vertebral body. So it's a very large length of area that can be stimulated. And these levels that could be stimulated would be expected to be appropriate. We should expect that we would be able to get good paresthesia coverage of the low back, buttocks, legs, all the way to the feet in most circumstances. So this is a really nice way to trial a patient who has pain in those territories, because you're sure to capture all of the potential neural targets for those pain generators. Picture, please. I can field any questions if there are. Dr. Beal may.
So, Dr. Lee, my only criticism here is you made that look too easy. That was should make it look harder next time. They think they can go out and do it straight away. The one request I would have, Jennifer, is would you show them, you have a close-up view of the patient's back with the needles and the leads coming out. Would you show them how to take a needle out to keep the lead in place? Because this will be secured down later with adhesive or Steri-strips or devices like a Stay-Fix, or some people suture these in. But you'll need to be able to take the needle out without moving the position of the leads, because you'll record this, the final position of the leads. You'll record this on AP and lateral, and then this is the trial. Whenever you go in to put your permanent implant, you'll want to mimic the position. You'll want to mimic the position that you had success. If you're stimulating toward the bottom of those electrodes or the top, you need to know that as well. So if they move a little bit, you need to take that into account to have continued appropriate stimulation. So she's going to show you how to take the needle out to be able to keep the lead in place and not move the position.
So that's a really good suggestion, because a lot of times at this point, this looked very easy, and it isn't always this easy. And so very often you feel like you're ready to exhale, and then you take your needle out and you lose some of that progress. So it is very important to have a good strategy for doing that. My strategy is to anchor the side of my hand on the patient's body and hold the needle. And then with my right hand, I pinch on the lead itself right here, and I don't move this pinch. I do not move my fingers from this lead on my right hand, which I'm moving now. And then I move my needle back to it without releasing the pinch I have on this lead. And then I move my pinch up further, and then I move the needle to it. But I am not moving the lead. I'm moving the needle out off of the lead. Come back to the skin and pinch at the skin on the lead, and then withdraw the needle all the way. So we can see if I did this correctly, and take a picture to test against my technique.
Picture, please.
So I actually advanced it a little bit, which is
That's the technique.
That's the best thing, is to advance it, if anything. Live, please.
So people will do this, and a lot of times, if you've seen, you'll do this by reflex. You'll take the needle and you'll move it toward the hand that's bracing the lead, not vice versa. And as you do that, you'll have a little bit of distal throw. Look, you can always pull the lead back, but once you take the needle out, it's not advancing. You're done. So this is a very good demonstration of how you do that. And so once these are pulled out, you anchor it using steri-strips and kind of the breast cancer awareness type thing. You loop it here and loop it around and put it down. You can use adhesive device called a Stay Fix or one of a number of different ways. But the important thing is to keep the leads in during the trial so they won't move. And if they do move, come back and fluoro the image to make sure and see where the leads are before you get any type of definitive information on whether the trial worked for the patient, what it did to their activity, what it did to their medication use, how well it did in terms of degree and in terms of percentage decrease in patients' pain and symptoms.
The last thing I would say is that I've removed the needle from over the lead, but I have not removed my stylet, and that is by design. If you remove the stylet and you need to advance the lead, you'll have difficulty. But if I have pulled my lead back at all, when I remove my needle and still have the stylet in place, I will be able to re-advance it.
Yep.
So at this moment, I have my stylet in place, though the needle is removed, and I'll demonstrate for you that I can still advance that lead. Picture. And I'm going to pull the whole thing out now, meaning the stylet and the needle. Live, please.
Can you show that proximal end of the lead to show them the stylet?
Sure. You're asking to have a...
Yeah, there it is.
This is the needle with the stylet through it, which I withdrew from the lead. And I can show you now that I have both of the stylets removed from the lead, if I try to advance this live, I'm going to have more difficulty because it's soft and it's going to just coil down at the entrance site between, at the location it's entering into the epidural space. Where you saw a moment ago how easy it was to advance my lead on the right side when the stylet was still in place.
Okay, well, that's excellent. Very, very well done. So,
Jennifer, Doug, you have a fellow there assisting. Could he introduce himself and let the audience know where he's doing his fellowship at?
What was that?
We didn't quite hear you. Could you repeat that?
Okay. My name is Siva Kapulu. I'm a pain medicine fellow at the University of Washington. And I'm a psychiatry background, but I'm interested in interventional pain.
what we'll do now, well done, exceedingly well done. We'll open it up for questions and comments. Yes.
So for the loss of resistance, we do like so I'm used to like air resistance. Can I just use the air instead of normal setting?
For loss of resistance, you can use anything. You can use air mixed with saline. You can use contrast. You know, what we do is we use contrast. So we market loss of resistance, regular Becton Dickinson syringe. We don't use anything special. So the techniques are acceptable. Techniques are really all over the board. And as Ramo mentioned earlier, epidural techniques are all over the board. So this is on label, right? FDA indicated on label, yes? DRG stimulation indicated on label. Epidural injections, FDA indicated on label? No, they're off label. So, you know, this is not something that is ever going to get an indication for this.
The other question is, so you said like a one level below.
1.5 to 2 levels below.
Oh.
This one was just a 1 level. I typically don't have patients this thin in my practice, so usually it's 1.5 to 2 levels below. But this patient is quite thin, and so just 1 level is fine at the thoracolumbar junction. Typically T12L1, L1, L2, because the interlaminar distance is the largest. And, you know, frankly, if you get a hematoma at L1, 2, it's much different than if you get it at T6, 7, or So the conus medullaris ends about L1 on most patients.
Okay.
That's
so
a point I want to bring up as well, is that as you're learning and being first introduced to spinal cord stimulation trials, you may want to start at L2-3, L3-4, and entering the interlaminar space at that point. Dr. Lee is an expert and has practiced for a number of years and feels comfortable with entering at that level. For the fellows in the audience, it is a good idea to enter 2-3, 3-4, those areas where you're not going to hit the conus or hit the spinal cord.
Yes, and it's also, patients' kyphosis and lumbar lordosis. So if you enter at 4-5, you're going to have to come way up to the lordosis and over like this. That's a lot of push. So you need to figure out where your target is going to be. Sometimes for cervical stimulation, I'll even start down here and run it all the way up because you have a lot of purchase. And sometimes we start it up here. Just depends on how difficult, whether or not there's epidural scarring, how long the leads are, whether or not you have a heavy stylet, meaning a stiff stylet versus a stylet that's not so stiff. Is it directional or is it straight? And you need to know that there's a difference between how robust the stylet is and whether it's directional. In each company, it's different. So, I've got my stylets loaded up. I know it's a stiff one with directional capability, and that kit comes to us. My fellow doesn't even know that, but they make it for us like that because that's what we like. But you just need to know what tools you have and how they differ, and which ones that you need for the particular problem you're trying to solve. At this point.